very much, Madam President. Ladies and gentlemen, it is my honor to introduce Dr. Yemurai Bikwa. Dr. Bikwa is a practicing orthopedic gynecologist, qualified 2 years ago. With a special interest in research in gynecology. She went to the paper, which comes from a dissertation, which is by the study. It's called the impact of COVID-19 lockdown on maternal outcomes in Harare, Zimbabwe, the comparative maternal audits.
Morning, everyone. Thank you for the kind introduction. So I'm going to present to you the paper that was published in the Journal of Research Global Health. And I co-authors, I'd like to acknowledge, we have come this far because I've stood on the shoulders of giants. So I'd like to acknowledge my co-authors, Dr. Yemurai Bikwa, who's been running around, he's also a researcher. Dr. she's an assistant professor with the University of South Carolina. Dr. Nadia, we've just seen off the podium, and of course, Professor Chirez Launcher, all of here. So the title of the article, Impacts of COVID-19 on Maternal and Perinatal Outcomes in Harare, Zimbabwe, Comparative Maternal Audit. So what we know is that as of March 2020, the WHO declared a global pandemic because of the SARS-CoV-2 virus. And here locally in Zimbabwe, on the 30th of March, we declared it a national emergency and a lockdown was instituted. Prior to this, we know that WHO and UNDP had already acknowledged that the sustained public health and social measures that were instituted would have a detrimental effect on the routine medical and public health service, and also on the social, mental, and health and economic factors. So what we noticed was that there was a reduction in utilization of antenatal care health services, as well as an increase in adverse maternal and perinatal outcomes. What we know, we didn't know much about the SARS-CoV-2 virus when it came, but based on previous pandemics, the other SARS pandemic, Ebola as well, we noticed that indirect effects during pandemics were detrimental. So worrisome trend has already been noted in other countries like Nepal, South America, including Africa. So as such, we still to evaluate the effects that the pandemic lockdown have had on our maternal and perinatal health system. So we worked out on two objectives. The first, to determine the impact of the lockdown, and the second one was to estimate the potential effect of the COVID-19 lockdown, decrease in coverage of maternal newborn health interventions and maternal and neonatal birth mortality, if we were to assume that it happened at a national level, using the life stage approach. So this was an analytical cross-sectional study of which effective data that we collected our two tertiary institutions, that's Zimbabwe Hospital and the maternity hospitals. These hospitals have a combined average delivery of about 25,000 babies per year when things are running. And we received referrals from the local clinics as well as from the district and provinces. So what we did is we went through all the obstetric records, the patients that were seen, neonates that were delivered, neonates that were attended to during the period. We took a period of March to August 2019, assuming that was a period without the lockdown and things were running normally. And then we compared that to March to August 2020, when we had the first wave of the COVID and the first lockdown in our country. Outcomes of interest were the total hospital delivery, live birth, stillbirth, vaginal delivery, cesarean delivery, vacuum deliveries. We also looked at uterine ruptures, peripartum hysterectomies, maternal death, and neonatal death. So we calculated our ratios for maternal mortality, perinatal mortality, as well as the cesarean section rate. Stillbirths were differentiated to fresh stillbirth and macerated stillbirth. We then use frequencies and percentages for descriptive statistics for the categorical variables. The year was considered as exposure of interest. 2019, like we said, we get the period prior to the pandemic, whereas 2020 was the period during the pandemic. We did univariate logistic regression models to assess the association between the year and the maternal or perinatal outcome. All statistical analysis was done using staff of those 16. We then went also to use the life-based tool to demonstrate the potential impact of the COVID-19 related disruption on all maternal and newborn healthcare services across the country. Now we'll go through our results. Unfortunately, we're not very visible. We'll just focus on the total column, the one with the far right side, and we'll compare 2019 to 2020. As you can see, in terms of total deliveries, the deliveries were reduced by about 3,000 deliveries. So from 11,300 in 2019 to about 8,400 in 2020. Vaginal deliveries also significantly reduced. If we look at breech deliveries, they were increased during the COVID period in 2020, from 215 in 2019 to 322 in 2020. If we also look at maternal mortality, the absolute figures seem to be higher. In 2020, it was 42 compared to 36 in 2019. This is just a graphic presentation to better visualize what I'm talking about. So if you look at the neonatal deaths, you can see that there was an increase of about 10%. Third deaths increased by about 17%. The viral infection rate declined by about 31%. There was a 23% decrease in vaginal deliveries, and total number of deliveries reduced by about 25%. If we look at adverse outcomes, maternal deaths, the absolute figure is higher in 2020 compared to 2019. Uterine ruptures doubled. There are 20 during the lockdown versus 10 prior to that. Peripartum hysterectomy was reduced in 2020 during the lockdown. And here's the maternal mortality ratio per thousand. We just looked at March to August 2019. The orange line represents 2020 during the lockdown. The blue line is the period prior to the lockdown 2019. And as you can see, there's an increased rate of maternal mortality. Perinatal mortality ratio, again, orange is 2020 during the lockdown, and blue is 2019 prior to the lockdown. There's an increase in perinatal mortality. So this is the statistical analysis that we then did. As you can see, the vaginal delivery, there's a statistically significant decrease in the number of deliveries that were carried out of the two institutions. The variant deliveries also reduced. Breech deliveries, the likelihood of breech delivery increased during the COVID pandemic. Vacuum deliveries were also reduced. Stillbirths were increased. An odds ratio of about 1.8. You can also see the uterine rupture almost doubled as well. Neonatal deaths increased. Late neonatal deaths, there was not much of a difference. Maternal deaths, whether there was an increase, was not significant. Then when we did the list analysis, we noted that we assumed based on the results that we received that there was a 25% decrease in the utilization of services. What would the effect be on a national level? So we find that if this occurred over a period of 1 year, there would be an excess of 343 maternal deaths, 2,658 neonatal deaths, and about 450 stillbirths. The maternal death would be attributed to the decline in emergency obstetric care, and maternal mortality ratio would be increased from 458 per 100,000 to 513. More than half of the additional neonatal deaths would be due to infection, sepsis, pneumonia, and so forth. And we noted as well that half of the increase in the stillbirth would be a result of decreased availability of cesarean delivery. So the specific findings that are worth highlighting that there were reduced hospital deliveries during the COVID pandemic. Also, the list analysis will show that there is an increase in adverse maternal and neonatal outcomes. But this is hypothetical. The most accurate information we could get based on the results that we have. And we do not have the market statistics. And then we also noted that there is an increase in stillbirth, macerated stillbirth in particular, which is a reflection of the antenatal care. So why would we have increased odds of vaginal delivery and breech delivery during 2020? So we postulated that this is possibly due to lack of theatre time caused by reduced staffing. During the pandemic, we had to change the work timetable so that we try and reduce exposure of the healthcare workers. Also, patients were reluctant, there was reluctance to take patients to theatre because of lack of PPE, which was something that plagued us during the first part of the pandemic. Another problem was that when the pandemic came, we were not prepared as a country. There were no standard operating procedures about institutes, infection prevention control, and things like that. So because of lack of SOPs, speculation also plagued how our hospitals operated. Another issue about health workers were very motivated. Obviously, they were afraid of contracting the virus when it came, so little was known about it. So there's poor motivation, and you see at some point during the pandemic that workers down to good to advocate for working. The other thing that we noted in obstetrics, we usually require blood, a lot of blood products, and during the pandemic, because everyone was confined to their homes, there were shortages of blood products, so the donors were not available. We usually get our blood from children, school children. Also, epilepsy was cancelled, so operating in emergency mode. This could have also led to viral infections and vacuum delivery is also reduced, possibly because of an overall reduction in the number of deliveries that were carried out in the public hospitals. There are also shortages of blood products, so definitely people be reluctant to take patients to theatre, and again, speculation swirling among the medical staff. The risk of uterine rupture increased. We know that most of our patients who go into theatre are related cases for previous cesarean infection. And because we have more antenatal clinics, it means patients are coming in as emergency and things are not running smoothly. So what do we learn from the study? We need to consider the indirect and direct impact of mitigatory response measures during pandemic. Zimbabwe implemented strict measures to flatten the curve and limit the spread of the COVID-19 virus, but little effort has put in curbing the impact of the indirect impact of the pandemic. The increase in adverse and perinatal outcomes documented in the study highlights the need to establish continuity of care and to provide essential services to vulnerable populations such as pregnant women and children. There's also a need to strengthen our health systems and grassroots. We know that most of our care is centralized, and during the pandemic, it was restricted movement. So it's possible that patients are not able to access the help that they need because they cannot tap into health institutions. Also, healthcare workers need support during the pandemic. They are vulnerable to physical as well as mental breakdown and lack of motivation. During these pandemics, we need to ensure that with education of these conditions, lack of knowledge and standard guidelines can draw fear and speculation, resulting in inefficiency in service delivery during pandemic. So we acknowledge that there are limitations to our study. This is effectively retrospective data analysis. The possibly these data are comparative as it was not collected primarily for the study. The data was collected between monthly and annual statistical records. And so we were limited as to the number of variables that we could work with. And the study could identify association of no causal relationship between established. And our study period, as you noted, ran for 6 months. This might not represent the typical secular trend at our hospitals. Another thing is that we only focus on the 2 tertiary hospitals Zimbabwe, and we are near the maternity hospital. Might have to be a true reflection that can be generalized to the whole country. And finally, when we did the look analysis, we just assumed that there was a reduction in utilization of services. We did not focus on the quality of care. So possibly this was an underestimate of the decline that we have experienced. So despite the limitations of this study, we've seen that we have records from over 18,000 patients, which is something that we can leverage on as researchers. The indirect effect of the COVID-19 on maternal and perinatal outcomes were observed. It is likely that other factors were explained the cause of these increased adverse outcomes. And then as a country, Zimbabwe needs to take consideration of the indirect effect on vulnerable groups such as pregnant women and children during response to pandemic. Thank you.
Thank you very much, Dr. Bikwa, for the interesting findings of the study. My insights, questions, conclusions. I think I wanted to know what I do. Usually the hospital age that are going to arise. If you look at that and you see that there was an increase, so care within the neonatal, so here that it's more of them are coming from the communication.
Unfortunately, we're not able to capture that data. We just looked at the perinatal adverse outcomes, but the birth people arrived and we managed to get that information.
Thank you very much for the presentation and the reminder. My name is Solomon Harare. What I would want to find out, what was the effect of the COVID on the healthcare workers as a contribution to what you are presenting? We just capture the data on the impact of the COVID itself on the healthcare workers during the health service delivery.
So we did not look at the direct impacts on the healthcare workers. What we, however, noted was that during May to August of 2020, there was an increased number of infection among healthcare workers. And if you notice on that graph, during that period, May to August, there was an increase in stillbirth, increase in perinatal mortality, as well as a reduction in delivery. Thank you very much. We did look at the direct causes. Yes, there was a doubling of the transactions during the COVID pandemic, and the peripartum variants actually it was not statistically significant. Those ones reduced, but it wasn't statistically significant. Sorry?
Well, should verify the figures. So you were saying you saw a 40% decrease in the But the question is on the slides.
The slide.
Ah,
There was
okay.
something like 50% increase in neutral and rapture rate, 40% decrease in guarantee. So I just thought that was interesting. What could be the explanation? Maybe I didn't separate.
Thank you for the next presentation. Impact of COVID-19. Why didn't you consider issues of constructed level? Why did you look at the scheme of uterine rupture? Because usually we know that it starts with before. So why didn't you look at the number of constructed levels?
So what we did was this data that we used was not primarily collected for this study. It was a secondary data analysis. So we're limited as to the variables that we can look at. We just used the statistical summaries that they used during in the labor ward in maternity for perinatal and maternal outcomes. So we couldn't look in detail. As noted, that was one of the limitations of the study. And then for Dr. Majangara, if you could just flag. If you could just put the slide up again for Dr. Majangara. So the cesarean hysterectomy rate actually decreased during the lockdown. I thought you were referring to just cesarean sections. As you can see, green there is for 2019 and blue is for 2020. So there were reduced hysterectomies in 2020. However, this was not statistically significant.
Yes, and my question was to say, did you manage to find an explanation why the uterine rupture rate is increasing, but cesarean hysterectomy rate is decreasing in 2020?
No, but I think this is because of the generally reduced number of deliveries that were taking place during that time.
Okay, maybe just one more question. Now we're out of time.
Thank you very much for that good explanation and the expose for the impact of COVID-19. What do you think the main causes of this kind of study? Because you took into account 2 tertiary hospitals only in Zimbabwe. Will you be going to another results of the whole country, or it is a smaller, it is an essay like to compare during a maternal and perinatal audit only? I mean, you told us that you took this study has limits, and it was only limited on 2 hospitals, and do you think that the results are going to be covered to the whole country with scientific research and with scientific consideration? Thank you.
Okay. I'm not sure I understood correctly, but what I think you're asking is, can we generalize these results to the entire country? So like we said, we use the LifeSave tool. It's a tool that is used to estimate the potential impact of adverse events on neonatal and perinatal outcomes. So it's an assumption. We use data from our local demographic health surveys and our MICs, together with the extrapolations that we got from our study. We noted that there was a 25% reduction in utilization of services. So we applied that across the country. So it's an estimation, yes, but that was the most accurate estimation we could get based on the data available that was available in the country at the moment.
Thank you. Thank you very much for that excellent presentation. Dr. Marjan from Kenya. Were the patients being admitted offered COVID-19 testing in those setups?
Yes, patients were being offered COVID-19 testing. It was a rapid test that they were being offered upon admission.
What was the uptake?
So during the peak of the pandemic, almost every patient had a test, especially those who were then going to go to theater or had any respiratory symptoms. I don't have exact numbers because I did not look at that, but generally based on the experience of working in these hospitals, we can safely say the majority of the patients were actually tested.
Thank you very much, Dr. Bikwa. Okay, another round of applause for him.